Good evening. I'm Kelly Gear-Ripken, National Chair of A Women's Journey. On behalf of Johns Hopkins Medicine's A Women's Journey, thank you for joining us this evening for our monthly webcast series, Conversations That Matter. You know, A Women's Journey always strives to improve your well-being through health education. During the next 3 decades, the population of adults with vision impairment and age-related eye diseases is estimated to double because of the rapidly aging U.S. population. In addition, the epidemic of diabetes, as well as other chronic diseases, will contribute to an increasing population of people who experience vision loss. Tonight, we are pleased to be joined by 2 Johns Hopkins Wilmer Eye Institute experts, glaucoma ophthalmologist Mona Kaleem and retina ophthalmologist Mira Sachdeva, to discuss the causes, diagnosis, and new treatment developments for latest efforts to reduce glaucoma, age-related macular degeneration, and diabetic retinopathy, the most common causes of vision loss. So please use your Q&A on your screen to ask your questions to the doctor, which you will respond, both of them will respond to your questions the last 20 minutes of our conversation this evening. Our webcast will conclude as usual at 8 p.m. And I want to take this opportunity to acknowledge and thank Johns Hopkins University's program Hopkins at Home for the production assistance. And you can visit their website for additional lectures and courses throughout the year. And now I am pleased to welcome Dr. Kaleem.
Thank you so much to the Women's Journey organizers and to Kelly for this invitation to be here. And I'll be talking about glaucoma. The reason why this is such an important topic for us to discuss is because glaucoma is actually a silent blinder, and we don't often know when we have symptoms, or there are very few symptoms to look out for. So I'm going to talk to you tonight about some of the risk factors, things to watch out for, and what you can do. So just a few basics about glaucoma. It's actually a chronic condition. So once you get a diagnosis, it's with you forever. And what happens in this condition is that there is damage to the optic nerve. The vision loss that occurs is unfortunately irreversible, and that's why it's very important to get screened, tested early on, to get an eye exam, and to understand what your risk factors are, and to figure out how you can work with your provider to minimize the risk factors and preserve your vision as long as you can. We know that 3 million Americans have glaucoma, and 120,000 Americans are blind from glaucoma. It is the second leading cause of blindness worldwide. And some other statistics are that there are racial disparities. We know that people of African descent develop glaucoma at 6 to 8 times higher rate than the general population, and are actually 15 times, have a higher rate of developing blindness by 15 times than the general population also. We know that people of East Asian descent are also at very high risk for a condition called angle closure glaucoma. And age is a risk factor. So are genetics. So if you have a family history, that's one of the risks for getting glaucoma. And there are many different risk factors, but the only one that we know that's modifiable, meaning something that we can actually work on right now or change at this moment, is to reduce the eye pressure. Next slide. My interest in glaucoma actually comes from a very long family history. My family comes from India, and in this picture you see 6 women. They are all sisters. 4 of them developed glaucoma, and all of them had children who developed glaucoma. And the woman who's sitting down with a checkered scarf on the far right of this picture with the white headscarf, that is my grandmother. Next slide. And this is her son who developed glaucoma, my father. If you have a family history of glaucoma, you can actually get it at a younger age. There's a very high risk among siblings. So if you have a sibling with glaucoma, then you should tell your other siblings about your diagnosis. Or if you know that a brother or sister has glaucoma, you should definitely get screened and try to get an eye exam at least once a year. A family history can increase your risk by 3-fold. Next slide. In terms of vision, that's actually a very broad term. There's lots of things that make up our vision. Our vision is not just our ability to read. It also includes things like our ability to see well in the dark or in low light conditions. It includes our peripheral vision. and things that can impact the way that we read, like glare and light sensitivity. So the impact that glaucoma has on our vision is that you can actually develop tunnel vision. So over time, it's like looking through a tunnel where you start to lose your peripheral vision. And so that can cause a lot of trouble if you're taking steps to look down, or you really need your peripheral vision when you're driving. Loss of contrast sensitivity makes it harder not just to read colors, but also to see well in the dark. So as all of us age, our contrast sensitivity naturally declines. That's why it's harder to drive in the dark, to see in the dark. And if you have glaucoma, that can certainly get worse faster. Loss of visual acuity, which is when you read on the chart at the doctor's office, they read a number to you, they say, oh, you're reading on the 20/20 line or the 20/40 line. That refers to visual acuity, which is your ability to see at distance. And loss of that actually occurs really late in the disease. And that's why I'm saying that this condition can just sneak up on you. If you go to the doctor's office and you read on the 20/20 line, but you're losing your peripheral vision, or it's becoming harder to see at night, then you could actually have glaucoma. And a lot of people have issues with glare and light sensitivity. It's actually one of the top complaints that I hear is that you have a lot of difficulty in sunlight. Sun really bothers you, lights really bother you, but at the same time, you feel like you don't have enough light to read. If you have any of these symptoms, then I definitely recommend coming in to get an eye exam. Next slide. This is an image showing visual field testing. So this is how we monitor peripheral vision in the eye clinic. The image on the far left is someone who has normal peripheral vision. And then this is someone who actually had glaucoma and was not treated in time. And then the very last picture shows a lot of dark patches. And so that this person has actually developed blurred patches or blind spots in their visual field. Next slide. And this is another image of what someone who has glaucoma may see. You can see the butterfly so vibrantly here on the left side. And then as time goes on with severe glaucoma, you develop that tunnel vision, and then colors are just not bright anymore. Next slide. Or what if this was your vision and everything looked great on the periphery, but you had like this one blind patch in the very center? So this could impact your ability to see a child playing on the road, or to see a street sign or a light like in this photograph. Next. The impact of this is really on your functionality. So people who have glaucoma have a harder time reading. They read slower and find it more difficult just generally to read. Feeling safe driving, seeing signs, cars on the side of the road, walking, feeling comfortable taking a step in front of you or going up and down steps. In-home activities like cooking, like if you do things at a stove, this is very important. If you open cupboards that are on top and you accidentally hit your head, this could be because maybe you didn't have good peripheral vision. And so again, your in-home activities can really be impacted. And if you're not performing your normal activities well, or you feel unsafe walking, or you've had a fall, then you might become depressed and then just stop going out. And so social interaction can really be impacted by this chronic condition as well. Next slide. The way we diagnose the glaucoma is with a complete eye exam that includes getting your eye pressure checked and also getting a dilated eye exam. I know that people don't really like to get their eyes dilated because it does blur your vision for a few hours, but it helps us, the doctors, to see to the back of your eye where your optic nerve is, and to detect if you actually have damage and have gone on to develop glaucoma. And this is a patient here who's actually getting their peripheral vision tested. Next slide. And this is a person who's getting their eye pressure reading. I do want to say that there are several different ways to check the eye pressure. You might have heard of something called an air puff, or maybe you went to a doctor's office and you had an air puff. So I don't recommend air puff. That's not a very good way of monitoring eye pressure. The gold standard way of getting the eye pressure checked is here, as is shown in this picture, on a microscope with one of the blue lights. So if you have glaucoma, or you're thinking that you have glaucoma, you should really get your eye pressure checked this way. We also have handheld machines that check eye pressure, and they're pretty good, but again, this is the gold standard. Next slide. This is a picture of a patient who's getting an photograph of their optic nerve. And again, as I mentioned, what happens in glaucoma is there's damage to the optic nerve, and that projects itself by means of loss of peripheral vision, contrast, glare, etc. So this is someone who's getting a photograph of their optic nerve so we can see what the size and shape are. Next slide. There are many different treatments for glaucoma. Probably the mainstay is going to be medication eye drops, and there's many different classes of medications. These days, we also have injectable medications for glaucoma, and we're doing work on that actively. And there's also some work being done on a drug-eluting contact lens. And the reason why this is important work is that some people forget to use their eye drops. Let's say you have a very busy lifestyle, or maybe you travel a lot. You may forget to take your eye drops with you. You might forget to use them. And so if you have an injection to your eye, that might be something that lasts for a few months. Or if you have a contact lens that has the medication in it, then that's also another way to continue to use the medication and not worry about the factors of forgetting to take your medication. Next slide. Another primary treatment, oh, I'm sorry, and this photograph actually shows a patient getting an injection of a glaucoma medication. Next slide, please. And this is the photograph I wanted to talk about, which is a laser treatment. I know we hear the word laser and we get kind of scared, like, oh my gosh, what is that? But laser treatment for glaucoma is actually very common, and it's one of the primary treatments, meaning using one medication is about equivocal to having this glaucoma laser in the office. So if you're someone who is very busy and active, you don't want to have to worry about taking a medication, you could do the laser. It's very low risk. It's done in the office, and it really just takes 5 minutes to do it. And the treatment can last for many years. It may prevent you from needing to use a medication. It may prevent you from needing a surgery. So it is a good first-line treatment. Next slide. We also do incisional glaucoma surgery, which it requires a step beyond medications and lasers. The gold standard glaucoma operation is called a trabeculectomy. This one has been around probably the longest. It's where we create a filter in the natural tissues of your eye. And the reason why we do this is, again, because the top modifiable risk factor for glaucoma is controlling eye pressure. And the way we're controlling the eye pressure is with the medications to reduce the production of the fluid in your eye, or to increase the drainage of the fluid. The laser does the same thing. It helps to increase the drainage of fluid. And what the surgery is doing is basically for people who, the filter of their eye is just not working well, nothing else is working, we do the surgery. And again, we're creating a filter for you. Next slide. There's some people who we recommend having a tube implant, which is where we actually put a shunt in the front of your eye. It actually looks more dramatic in this picture than it really is. Someone who has one of these tube implants or has the other procedure called the trabeculectomy, these surgeries are very sophisticated. You can't see it when you look at someone's eyes. It's just something that the eye doctors see when they do the examination. Next slide. And now we have these great surgeries called minimally invasive glaucoma surgery. And we as eye doctors, we use the acronym MIGS for minimally invasive glaucoma surgery. And this is basically where we take some kind of a system and we open the drainage canal of the eye. And this is the drainage canal on the inside of the eye. The drainage canal runs like a band around the front of the eye. And so the reason why people get high pressures is because the filter of that drain is just not working as well. So what these minimally invasive glaucoma surgeries do is they actually open the canal. Sometimes we just dilate it open, and sometimes we put in a little stent. These surgeries have been around for the last few years. They're very good surgeries, again, highly sophisticated. They can be done with cataract surgery, or we can do them just on their own for people who don't need cataract surgery quite yet. But the recovery is a lot faster and the downtime is less with these ones. Next slide. And, I also want to touch upon different mechanisms of glaucoma, because as I mentioned, we know that eye pressure is one of the risk factors. And eye pressure, we don't actually know what the normal range is. What one person can handle for eye pressure, another person may not be able to handle. There are other things that we think cause glaucoma, like oxidative stress to the optic nerve and problems with blood flow. Next slide. And this is important because there are things that you can actually do for yourself outside of medications, lasers, and surgery. We know that people who eat a diet that's rich in antioxidants may in fact have a lower risk of developing glaucoma or slower progression of their glaucoma. And again, that goes back to the fact that we think that maybe oxidative stressors in the body to the optic nerve may have some impact in causing glaucoma. Eating a diet rich in omega-3 fatty acids is very good. So things like fish oil, walnuts, flaxseed, and it's okay to drink tea and coffee. In fact, hot caffeinated tea, some people think there may be some protective factors there. But in terms of caffeine intake, it is totally fine to drink tea and coffee. But I would try to avoid really heavy caffeine intake. If you're someone who's drinking 4 or more cups of coffee a day, you may want to rethink that. Next slide. Lifestyle is also very important. We know that patients who exercise for 30 to 45 minutes, 3 to 4 times per week, are slower progressors to glaucoma. I would recommend avoiding exhaustive exercise that involves breath holding, like severe weightlifting. When you're lifting really heavy weights, exhaustive heavy weights, you can increase your eye pressure. I do encourage you to lift lower intensity weights to build the strength in your body. It's very good for us women. It helps to prevent the weakness that can occur over time from osteoporosis. So you do want to continue to lift something. And other things to add to this are things like meditation. There's actually some very interesting work being done in India, and also that we're doing here at Hopkins, looking at meditation and how that can impact eye pressure and worsening of glaucoma. Yoga is actually great for glaucoma as well. There's something called pranayama breathing, and these exercises involve, it's essentially alternate nostril breathing. They can help us to regulate our blood flow through our breathing. And in addition to being very relaxing and good for our overall health, this can potentially impact, again, the blood flow and have some alteration to the eye pressure. I would avoid positions where your head is down below your heart for 5 minutes or more. So that would be like a headstand. The downward facing dog position, which is part of yoga. I would again avoid that for a prolonged period, but it is safe to do yoga. Next slide. Also, another thing that I always encourage people is to create a partnership with your providers, to be an advocate for yourself, for your family members, ask questions, get information. There's a lot of great information on the internet. I'm actually going to share some resources with you. Next slide. And there are things that you can do yourself to improve your functional vision. You can work to make things in your home brighter. So maybe change the lighting in your house, make things bigger. So nowadays, a lot of us have phones or different types of screens where we can pinch to make something bigger. So that's something you can do if you feel like you're having a hard time reading. Why not get a tablet, a Kindle? You can read on your phone, but just pinch to make it bigger. You can also change the contrast in your technology. A lot of people actually take their phones or their computers where you're reading black print on a white background, and they just change it to reading white print on a black background. And you would be so surprised by how much better people function with that. Using audio. I mean, these days, audio is in so many things. Our phones talk to us. Everything is talking to us, and we can talk to it also. I can talk into my phone and it can text the message. So instead of me having to look at those small little letters on my phone and type in, I can just simply hit the audio button on my phone. I can talk to it and hit send, and it's going to send my text message. Other things like organizing your home and minimizing clutter will help prevent you from falling, and doing things to minimize glare. So instead of buying instead of in your home having these like bright shiny floors that we think are so beautiful, why not try putting some carpets down that reduce the glare, or maybe changing the lighting in your home so that there's less glare overall. So all of these are just tips. You can actually, like I said, be your own advocate and do things for yourself. You may not always have time to talk to your doctor about these things, but again, these are things that you can just do on your own. Next slide. These are some images of different types of technology and tools that you can purchase on Amazon, or really even at a hardware store, or lots of different stores. I'm not promoting any particular products or brands. These can really be purchased in many different places, including a vision rehabilitation doctor's office. Next slide. And I mentioned some resources. I actually have a podcast with my colleague, Dr. Harry Quigley. It's called Diagnosis Glaucoma. We have our own website, diagnosisglaucoma.com. You can listen to our podcast on that website, go to YouTube or any podcast player. The Glaucoma Research Foundation is based on the West Coast, and it is an excellent resource for patients to learn more about their condition. There's a book that I wrote with my colleague also, Glaucoma, What Every Patient Should Know, and that is available electronically and as an audiobook. And another one of our colleagues, Dr. George Spaeth, wrote a great book called Glaucoma, What You Need to Know to Preserve and Enhance Your Health. The World Glaucoma Association website, the American Glaucoma Society, and the Hadley website are great resources as well for patients. Next slide. So take-home points, glaucoma is a chronic condition, but fear not, it can be controlled. Having a good partnership with your provider is going to help you get through it and preserve your vision for as long as possible and hopefully forever. Most people with glaucoma actually can't see their whole lives and do not experience blindness. And there are a lot of different treatment options, which is great news. Eat a healthy diet and have a good lifestyle full of exercise, and be an advocate for yourself and for your loved ones. Make sure you ask questions, get an exam at least once a year or at least once every 2 years. Next slide. We get asked a lot of questions about, well, what are you doing in terms of research? What's new in glaucoma? We're looking a lot at telemedicine and how we can monitor glaucoma or eye disease at home. We're actively doing that work at Johns Hopkins. Some very interesting work that I'm doing in particular is looking at how shared decision-making between patients and providers can be improved, how we can help patients to communicate better with providers, and how we can actually take the patient's voice into consideration when we provide treatment options. We're looking at ways that medications can be implanted in the eye, and that will again help to reduce the cost of medications and to hopefully improve compliance. I'm also doing work, and all of us are doing work at Johns Hopkins in minimally invasive glaucoma procedures and the next generation. And we have colleagues here at Johns Hopkins who are looking at stem cell therapy and neuroprotection. If you'd like more information, please do contact Daniela Fried, whose information is here at the bottom. Next slide. Or you can actually just contact me directly. I have listed my email address here, as well as a link to the Diagnosis Glaucoma website, and I welcome any questions that you have at the end of this program. Thank you very much.
Great. Thank you, Dr. Kaleem, and thank you for sharing your personal story as well. We'll see you after we hear from our next physician in the Q&A. So now I'd like to welcome Dr. Sachdeva.
Thank you so much, Kelly, and thank you all for the opportunity to share some information about two of the most common conditions that we see as retina specialists in the clinic, and that is diabetic retinopathy and age-related macular degeneration. So I could probably spend the entire session on either one of these two conditions, as there's a lot to talk about, but I will try to highlight some important features of both and some new developments in the treatments and diagnosis as well. So we'll go to the next slide, please. So I thought I'd start with some orientation of which part of the eye we're talking about. So the retina lines the inside of the back of the eye wall. It's kind of, I sort of describe it sometimes to patients as like wallpaper lining the back of the eye wall, or it's like the film in the camera, at least the kinds of cameras we used to use before iPhones. It's the very thin neural tissue that sends signals then back through the optic nerve to the brain. And the macula really refers to the very central part of the retina that's highlighted here in the red square. It, as you can see, only comprises a small area of the retina, but is arguably the most important part of the retina because that's where the central sharpest vision comes from. And so diseases that affect the macula affect central vision and affect things like reading, like driving, things like that. So if we can move to the right side of the slide, you'll see that the retina also has a very complex architecture in cross section. So here on the pictures on the left, we're looking head on at the retina. From front to back, though, there are many layers of cells that make up the retina, as shown in the top diagram. And, different diseases can affect different layers of the retina. So it's really important to kind of distinguish which part of the retina, front or back, is affected. So we luckily have an imaging modality that we use all the time in the retina clinic called OCT, or optical coherence tomography, that gives us a way of looking at the retina in cross-section non-invasively within a matter of a few seconds, really. And so this is an example on the left side of that black and white picture is the head-on view of the macula, so the eye is looking right at us. And then if you were to slice the eye right where that green line is, and turn the eye so that it's looking upwards towards the top of the screen, that's the cross-section, that corresponding cross-section of the macula or the retina is what you're seeing on the right. So you can see all the layers are actually pretty well defined, considering this is non-invasive. And as I said, different diseases affect the macula or the retina in different layers. So for example, diabetic retinal disease tends to affect the inner retina, so the part of the retina that's sort of to the top of that image, whereas macular degeneration affects the outer retina, so towards the bottom of that image. And we, again, use this all the time. So in the next slide, I'll start delving into diabetic retinopathy. This is the leading cause of blindness in working age adults. It affects approximately 1/3 of individuals with diabetes over the age of 40, and approximately 1/3 of those individuals have what we would call vision-threatening disease. So when we talk about diabetic retinal disease, it's actually two different manifestations that can happen independently or together. So on the next slide, we'll talk about diabetic retinopathy specifically. That in the early stages, which we call the non-proliferative stages, you can see here what the retina might look like. You can see little red spots, which are hemorrhages. You can see in the middle slide, as the blood vessel changes get more severe, that the vessels become sausage-like, as we describe it. Essentially, the blood vessels become more and more abnormal, so that blood flow to the retina is compromised more and more. And ultimately, if enough blood flow is compromised, the retina tries to actually compensate by making new blood vessels. And at this stage, which is called proliferative diabetic retinopathy, and you can see that on the far right, those new blood vessels, it's a good attempt, but those blood vessels are not normal. And so they can cause lots of problems like bleeding, for example. And if left untreated, proliferative diabetic retinopathy has a 9.4% risk of severe vision loss in 2 years due to things like bleeding from those abnormal vessels, retinal detachment that can occur because those blood vessels form scar tissue that forms on the surface of the retina, or just really severe lack of blood flow to the central retina. So we have to be more aggressive when trying to deal with proliferative diabetic retinopathy, but really for any stage of diabetic retinopathy, the most important thing that is recommended is to control the blood glucose or the blood sugar levels in patients with diabetes. So on the next slide, you'll see a classic landmark study really that showed this, although we know this from many studies. So these are data from the Diabetes Control and Complications trial, which was a very large randomized control trial of patients, in this case with type 1 diabetes, that were randomized to either conventional glucose control or intensive blood glucose control or sugar control. And the endpoint that was looked at was retinopathy. And so you'll see here if you could advance that there was, with intensive glucose control, a 76% adjusted risk reduction in the development of diabetic retinopathy. And not only that, in people that had diabetic retinopathy to begin with, there was also an adjusted risk reduction of 54%, if you advance these for me, in the progression of diabetic retinopathy. So basically, blood glucose control, we know from this and many other studies, is important for every patient, every individual with diabetes, in order to reduce their risk of onset of diabetic retinopathy as well as progression. So, but when proliferative diabetic retinopathy or those advanced stages occur, we know again that the risk of vision loss if left untreated is quite high. So we again have to be more aggressive, and the eye itself needs to be treated. In the next slide, you'll see the really mainstays of treatment for proliferative diabetic retinopathy. The tried and true treatment was laser. And the first picture on the advance to the next picture, would be an example of, again, proliferative diabetic retinopathy. So there's extensive little blood vessels covering the optic nerve. And then if we advance 2 more, you'll see that with laser placement, those are those brown spots in the picture around the areas where the new blood vessels are. Those blood vessels can actually shrink up and regress. The way we think this works is that the laser is actually intentionally destroying part of the retina, which may not sound good, but the purpose is that that area of retina is abnormal and sort of sending out a help signal because it's not getting enough blood flow. And so it's inducing the abnormal new blood vessels. So as I said, laser's really been around for many, many years, and it works very well to treat proliferative diabetic retinopathy. It has been shown to reduce the rate of blindness if that condition occurs. But nowadays, we actually more commonly tend to use a more targeted approach to get those blood vessels to go away. And that's demonstrated in the bottom here. In this case, we inject into the eye a medication that targets a molecule called VEGF, vascular endothelial growth factor. And many, many studies have shown elevated levels of VEGF in diabetic eyes, as well as macular degeneration, which we'll talk about soon. And so these 3 medications listed here are the most common ones used in the retina clinics. So we inject this into the back of the eye, as demonstrated on the bottom right. And it does a great job too, actually, of getting the blood vessels to kind of shrink up and regress, and can as similarly reduce the rate of vision loss, just like the laser. There are some pros and cons, like with everything. So the injections have to be given at least initially every month or every 4 to 6 weeks. And, there are small risks, a very, very small risk of infection. That's what we worry about the most. But, so it can be somewhat of a burden for patients to have to come in that often. And, it's a little bit intensive, but we tend to use it a little more often because it's a little more targeted, and we're not intentionally destroying any of the retina. So these are treatments for diabetic retinopathy. I mentioned diabetes can affect the retina in 2 main ways. The other way is when it affects the vessels in the very center part of the retina, or the macula. So on the next slide, you'll see examples of this. This is called diabetic macular edema. So again, it's a blood vessel problem, but here the blood vessels start to leak, and they start to leak fluid into the macula and cause swelling. So here's what we might see on dilated exam. On the upper left is an example of a macula with no diabetic macular edema. And then progressively to the left and then at the bottom is increasing amounts of swelling and leakage from these blood vessels in a patient with diabetes. What we see are the red spots, little hemorrhages. The yellow spots are areas of fluid leaking out, or it's lipid actually. And then if the next advance, if you could advance the next 4. You'll see the OCT images that correspond to these exam findings. So again, the OCT shows us a cross-section of the macula in real time, non-invasively. And again, in the upper left, that's an example of a normal macula where there's no swelling. That's a normal shape. And then as you can see, the increasing severity of macular edema, or DME, is manifest as a thickening of the central retina and accumulation of these dark areas of fluid. So because the macula, as I mentioned, is responsible for your central vision, patients that have DME often experience blurry vision or reduced central vision. So we do treat them if it's affecting visual acuity. And the mainstay of treatment here is the same treatment that I mentioned as one treatment for diabetic retinopathy, and those are intravitreal injections of those agents targeting VEGF. So on the next slide, you'll see an example of one of my patients, who's a 66-year-old man who had has type 2 diabetes for 12 years. And he came in with reduced vision to about 20/50 on the eye chart in the clinic. And on his OCT scan in the clinic, you can see that there is thickening of the central retina, or diabetic macular edema, and those circles represent fluid that's leaked out of the abnormal blood vessels. So with the next 2 advances, you'll see that he received 1 intravitreal injection of one of these agents, Eylea, and after just 1 injection, all of that swelling and edema has resolved. He has a normal macular shape now, and his vision improved to his baseline of 20/30. So not every eye responds with 1 injection. There's a lot of variability in response. There's a lot more nuance to the treatment, but this is the first line standard of care treatment now for diabetic macular edema. So now we're going to shift gears to another condition of the macula, and that is age-related macular degeneration. We'll start on the left, where I wanted to mention drusen, because drusen are the hallmark of macular degeneration and how we diagnose it. Drusen refer to the yellow spots that you see in the macula here. That's what they look like on exam. Again, now with the OCT, again, with the cross-sectional image of the retina, you can see that those drusen are actually located under the retina. So they are deposits and elevations under the retina. Drusen actually comes from the German word for rock, or geode. So I guess someone thought these looked like little rocks at one point. And we don't 100% know exactly what they're made of, but they're thought to be byproducts of the retina working really hard. And the layer of cells beneath the retina is supposed to get rid of all these byproducts of metabolism. Sometimes that layer of cells doesn't work quite as well as it should, and these deposits can accumulate. So, everyone's allowed to have a couple of small drusen, as long as they're small and as long as there aren't that many of them. Once they become more numerous or pass a certain threshold in size, that falls into what we would diagnose as dry macular degeneration. So in the top panel on the right, the top three pictures, on the right side, you'll see sort of the progression of what can happen with dry macular degeneration. So let's focus on in the middle, where that would be called intermediate age-related macular degeneration, where you have several, or you have at least one large drusen. And then as macular degeneration progresses and stays dry, the retina can become thin in the areas of these drusen, and it can lead to what's called geographic atrophy or thinning of the retina. And you can see that in that yellow circle on the top right picture, that you're actually looking at the blood vessels even beneath the retina because the retina has become so thin there. And certainly patients that develop this geographic atrophy can have a blind spot where that atrophy is located. Intermediate macular degeneration can also progress in a fashion where it converts to what we call wet. And that's where abnormal new blood vessels form in the bumps underneath the retina, and they can leak and bleed. And so on the bottom right picture, you can see some bleeding that we can see on exam when this happens. And then in that OCT black and white image in the bottom center, you can see what that might look like in cross-section where there's blood and fluid, that dark sliver underneath the retina there. So that certainly can cause, a blind spot and loss of central vision, and many people lost vision significantly from that until now, where these days we do have treatment for that, which we'll get into in a moment. But because advanced AMD can cause loss of central vision, in the next slide, you'll see what an eye with advanced AMD might see. So on the far right, you can see the blind spot obscuring central vision. I like the top panel because the central image shows what a lot of patients with macular degeneration describe even before things get that advanced, and that is a little change in contrast sensitivity. So I think they need more light. And then at the bottom of the slide shows one of the strategies we ask patients to use to monitor their vision, and that's the Amsler grid. So on the bottom left is what it should look like normally. The bottom right shows what some patients with AMD experience, where they have a distortion or a spot missing. So let's move on to the next slide, where I just wanted to go over a little bit of epidemiology of age-related macular degeneration. It is the leading cause of severe vision loss in individuals over the age of 55 in the developed world. And I think that point speaks to that there are some differences depending on ethnic background, and genetics plays a role. So it affects about 8.5% of people worldwide between the ages of 45 and 85, but it's more common in people of European ancestry compared with those of African, Asian, or Latin American descent. And nearly about 2 million Americans have advanced AMD, which is either the wet form or the geographic atrophy dry form. So in the next slide, we'll talk a little bit about risk factors. Unfortunately, age is probably the biggest risk factor, and there's not much one can do about that one. But there are some other risk factors that we don't have much control over either, including family history. There are several gene mutations that have been associated with AMD or AMD risk progression. The two most significant ones are complement factor H, which is involved with immune system function, and the other one, ARMS2, we actually don't know what that does yet, but there's a lot of ongoing research about that. In terms of modifiable risk factors, smoking is probably the most significant modifiable risk factor. And then there are protective factors, very similar to what Dr. Kaleem was talking about with glaucoma. Diet and exercise can reduce the progression of AMD. So higher dietary intake of antioxidants and increased physical activity have shown to be beneficial. So on the next slide, I just wanted to talk a little bit about, so in terms of risk, we talked about some risk factors and protective factors. That being said, it's very hard to predict, and we don't really have a great way of predicting in any given patient or any given eye the likelihood of progression to late stages of macular degeneration. There's no surefire way, but I just wanted to highlight that there are some features on dilated exam that can help give us an idea of that. And this is a scale that's been around for a long time. But for example, we look at things like pigment changes, like the little brown spots you can see in that picture, and the presence of large drusens, so of a certain size. Give each of these points, and then they do it for each eye, and you can see as the points add up on the right side, the risk of progression to late AMD adds up as well. So this can provide some clues to that. But what can we do to potentially slow down this risk of progression in intermediate dry age-related macular degeneration? There is one thing, and on the next slide, you'll see it is something you may have heard of called AREDS, the AREDS2 specifically formulation. This is really was the result of two very large NIH-sponsored trials that tested a mix or a combination of antioxidants. in patients with macular degeneration to look for any change in the progression. And the results of the first ARED study are shown on the bottom left, where the AREDS formulation was shown to confer a 25% risk reduction of progression to wet AMD in patients with intermediate AMD. So it really does seem to work. Now, beta carotene is a component of the original AREDS formula, and that has been shown to increase the risk of lung cancer in smokers. So on the right side of the slide, you'll see that the National Eye Institute, if we could advance to the right slide, you'll see that the National Eye Institute did a second follow-up study, the AREDS 2 study, where they replaced beta carotene with lutein and zeaxanthine, which are antioxidants, and that worked actually even better. So that formulation is called AREDS 2. That's what we recommend for patients with intermediate age-related macular degeneration. And I just included the ingredients of that because there are many brands and many companies that make different variants of this, but I always tell my patients that as long as it has the total daily dose of what AREDS 2 has, they should be equivalent. So then that's intermediate. What about advanced AMD? Well, in the next slide, you'll see that, as I was mentioning, thankfully, we do have treatments for wet AMD these days. They are, again, actually the exact same medications we were talking about for diabetic retinal disease that target abnormal blood vessels, so target VEGF. So this is just, again, one of my patients who came in with new wet macular degeneration in the OCT. You can see there's elevation of the retina with, actually that's blood and fluid under the retina. And then if we advance 2 more, you'll see that after intravitreal injections of Eylea, this medication that we use to target the abnormal blood vessels, after 4 of them, the blood and fluid totally resolved and her vision improved to 20/50. Now, treatment with these agents requires often monthly treatments, and in AMD versus diabetic retinal disease, it could be indefinitely even in some patients, and every eye responds differently. So on the next slide, you'll see that there have been several approaches to try to optimize even the current treatments that we have for wet AMD, and some of these have been recently available. One strategy is to have a more sustained delivery of the same agents that we use right now. So the port delivery system, also called Susvimo, is basically a little depot that's shown in the right picture there, surgically implanted into the eye and filled with one of these anti-VEGF agents, ranibizumab. And instead of injections every month, let's say in the clinic, the refill can be done every 6 months. And the studies that led to its FDA approval showed that they were non-inferior in terms of efficacy. So that was FDA approved in 2021. It's actually under temporary recall just because of some potential concerns with a little small piece of the depot, but hopefully we'll be back on the market soon. And all the patients I know that have had it really love it. And then the other strategy is looking beyond VEGF to other agents that might be targetable. So recently approved as well, a medication called Vabysmo or faricimab targets not only VEGF, but another molecule, Ang2, involved with blood vessel abnormalities. And so the studies that led to its approval in 2022 showed that it could allow extension instead of monthly treatments, perhaps up to 4 months. And this is injected in the clinic, so similar to the agents we use now. And then on the final note, I just wanted to mention advanced dry AMD of geographic atrophy, because up until very recently, there was absolutely no treatment for this. So this is very exciting that the FDA approved in February of 2023 the first treatment for this, for geographic atrophy. On the far right, you can see what geographic atrophy kind of looks like on one of our imaging modalities. So the black area there are areas where the retina is actually gone or thin, because it's so thin that it's absent. From the top to the bottom shows the progression that can happen over time. So peptidoglycopan or Syfovre was approved. It targets the C3 complement pathway, and it was shown to slow the growth of that area of geographic atrophy in patients. So, it's actually not available yet at Wilmer, but hopefully will be soon and may be beneficial to some patients. It has some limitations, which we can talk about, but it's certainly very, very exciting. And so I think my final slide is just summarizing what we talked about, that just overview damage to the macula can affect the central vision. Overall systemic health or your body's health is very important for retinal health. Diabetic retinopathy and AMD are very complex diseases, but with appropriate diagnosis and treatment, vision loss can definitely be reduced. And I mean, I think retina is very exciting. I guess I'm biased, but there's lots of new treatment approaches that are coming up, every year even to improve the way that we care for patients with these diseases. So I will stop there.
Great. Thank you so much. Lots of information, lots of great information. So why don't we just jump right into the questions? So I'll ask them, and both Either one of you can answer them. Obviously, if it pertains to what your specialty is, great. If not, if they pertain to the both of you, please feel free to jump in, okay? So our first question is from Lisa, and she'd like to know, do contact lenses worsen either one of these, any of these diseases that both of you talked about?
I guess I'll start. Maybe I'll just start and say no, contact lenses don't have any known effect, and I wouldn't expect them to really have any negative or positive effect on diabetic retinopathy or AMD.
Mm-hmm.
And same with glaucoma, no effect of a contact lens on that condition.
So really no eyewear, nothing like that is going to hurt anybody, having any type of eyewear.
No.
Correct, right. Yeah.
And there was some suggestion at one point that, for example, UV light could contribute to AMD progression and things like that. So, I mean, I think all of us, Mona, you can't correct me, agree that sunglasses are a good idea in general for lots of things. But to be honest, there hasn't really been shown to be a direct, that potential association of UV light and AMD has not really panned out in studies after the initial one. So, but nonetheless, I would recommend sunglasses.
Sure. So also on that note, because that actually was a question from someone, does the sun add to you possibly getting any of these issues with your eyes? And also with that same question is, does eye makeup remover or any of the eye drops, that are over the counter that people use? I know there's drops for allergies, there's drops to just clean your eyes out. Eye makeup remover or anything like that that you're, using on your eyes, or any of them. The question is, are you more susceptible to, getting glaucoma or macular degeneration, any of those?
Not any of the over-the-counter allergy, not any of the over-the-counter artificial tears, but sometimes medications that you take for allergies can actually put you into a situation where you develop glaucoma called angle closure. Those aren't eye drops specifically, they're other types of medications that we take for allergies, like oral medications. That was going a little bit beyond the question.
I know, that's very interesting. So you're saying that some medications, some oral medications can be a precursor to glaucoma. Is that something then that's in, when you get your prescription and it lists all of the things, the possible adverse reactions and things like that? Would that be listed on these medications?
Yes, usually they're antihistamine medications, which again are typically used for allergies. Also, steroids can induce glaucoma, and that can be an eye drop. Those are not over the counter, but they can be eye drops or ones that you take by mouth or through an IV for a treatment for something else.
And is that because of the pressure from steroids?
Correct. It increases the eye pressure. And then the antihistamine medications, actually, they change the anatomy of the eye a little bit so that it can actually cause glaucoma, something called angle closure glaucoma.
Interesting. So on that note, for our audiences, that's an interesting, some people don't read the back of packages, right? Whether it's over the counter or when you're getting a prescription, they pile it all in your prescription pack, right? When you pick it up. So this would be a good point to mention that you really do need to read perhaps some of these adverse reactions or reactions that could happen. And if you're concerned about it, you ask your physician, I would imagine.
Correct.
Great. Good. Thank you. So our next question from Jan is, can cataract surgery cause blurry vision?
Well, cataract surgery is usually done to help improve blurry vision. But yes, any surgery to the eye, any treatment can make vision get blurrier. And it's one of the risks of all procedures, but it is a risk of cataract surgery that vision can get blurrier. And generally, we're able to correct people to as close to 20/20 as possible. So if you're someone who is still experiencing blurry vision after cataract surgery, then do go in for a full evaluation.
Great.
And maybe I can add, Kelly, that there are you might not think about that can happen after cataract surgery that could be causes, as Dr. Kaleem was saying, of blurry vision. Like, for example, the retina. We were looking at examples of retinal edema from diabetes, and in the slides, you can get something called cystoid macular edema, which is like an inflammation-mediated swelling of the macula after cataract surgery. And I don't know off the top of my head the statistics for that, but it's not uncommon, certainly that we see it in the retina clinic, and that can affect central vision. So it can be surprising for patients who are, maybe even doing well initially after cataract surgery, but then things start to get blurry, and that can be treated with a couple of options, either drops or injections.
So would LASIK surgery fall into that category? Anybody going in to get something like that done? Is that
With this one, that's a good question. As far as I know, it's not really a common association. Cystoid macular edema or central swelling is not commonly associated with LASIK per se, but more in surgeries in the eye, so like cataract surgery and other procedures like that.
okay? Great. Our next question is from Kadia, and she would like to know: are vitamins effective in helping AMD and glaucoma?
There are no vitamins for glaucoma. Sorry.
Zip. Yeah.
Yeah.
And really then, is there, on that note, is there any way to prevent it, be proactive, or if you're going to get glaucoma, you're going to get it?
Genetics and age and race can predispose us to getting glaucoma. The goal of treatment is to try to detect it early and get treated in time, and then to stabilize vision. And in terms of vitamins, Dr. Sachdeva will probably comment on how vitamins are very helpful for AMD.
Yeah, that's kind of it's a definite yes for macular degeneration. that the AREDS 2 formulation that I mentioned in the slides has been proven to reduce the risk of progression. But I guess I'll just say one thing, which is that was shown to reduce the rate of progression from intermediate dry macular degeneration to wet macular late stages. So in other words, a lot of patients even will ask me, patients who don't have macular degeneration or who have very early findings, whether they should take AREDS 2. And I mean, that's a difficult question because there's no evidence that will really make a difference, because the risk of progression is so low in those cases. But, I mean, it's hard to say. The antioxidants might have some benefit that we don't know.
Sure. So our next question, thank you both very much for that, from Susie. She would like to know, if you are a diabetic, how frequently should you get an eye exam?
That's a great question. So basically in type 2 diabetics, one should have a dilated eye exam of the retina at the time of diagnosis. For type 1, it's usually within a few years, like 5 years of diagnosis, because it takes some time for retinal findings. But how frequently actually it depends on if there are any findings. So if you have any signs of diabetic retinopathy on your exam, or diabetic macular edema. So for a patient with diabetes or an individual with diabetes that doesn't have retinopathy, the minimum is every year. You should have a dilated exam every year. If your ophthalmologist, your optometrist finds diabetic retinopathy, findings on your exam, then it depends. It could be anywhere from every 3 months to every year, depending on how severe those findings are.
Great, thank you. And Dr. Kaleem. So the question from Renee, she'd like to know, how far off are the research from being approved with the EJ home monitoring and long-lasting medications?
We actually have a device right now that monitors eye pressure, and it can be used at home. So that's already approved. If you're interested in renting or buying one of those machines, we have a program at Johns Hopkins at the Wilmer Eye Institute where you can rent or buy a home monitoring device. And I also recommend a website, myeyes.net, where you can do the same, buy or rent an eye pressure monitoring device. In terms of monitoring your vision, there are tests where you can monitor your visual field and your contrast to sensitivity online. They're just screening tools though, and really the best exam you're going to get is in the office, but in terms of where are we with the progress of that research, it's ongoing right now. And so right now, the main device that we can tell you about is the home monitoring eye pressure device, but the others are in the works, and we're not very far off from really having those out there for patients.
Mm-hmm. So are most of these devices covered by insurance?
If you get a note from your doctor, a prescription, it may not be entirely covered, but you can probably get some kind of rebates, or there are programs within the insurance companies where you can get some kind of a deal, but it may not be free.
Right. Okay, great. Thank you. Our next question is from Amy. She'd like to know, should patients use the Ansler grid at home? Am I pronouncing that right?
Yes, the Amsler grid. Yes, it's a very useful tool. I mean, we kind
Do you
of
want to maybe say what that is again? I know that you mentioned it, but just quickly, yeah.
absolutely. So it's that grid that was on one of the slides in my talk, where it's essentially a grid with a dot right in the center. And it's a really useful tool, in particular with patients with AMD, but actually with any macular disease or disease affecting the central retina. I guess since we're talking about it, I'll just mention it's very important for anyone using that to make sure to remember to cover one eye when you're looking at it. So do one eye at a time, because, I know it may sound simple, but it's very easy. And I think we've all seen patients who have not noticed a change in one eye because both eyes were open and their other eye was compensating for it. So you cover one eye at a time, you look at the grid, look at the central circle, and make sure that the whole grid is there and that there are no spots missing, in other words, and make sure that the lines are straight and there's no distortion. I mean, it's not a specific method. Certainly lots of things can cause distortion and spots, but it's something that can be a really useful tool.
Mm-hmm. Great. Thank you very much. Dr. Kaleem, this question is from Joan, and she'd like to know at what age or when should you start to check for glaucoma, especially if you know it's in your family history?
For everyone, I would start around the age of 65, but if you have a family history, I would actually start at 45.
45. So is that part of your norm? Would you just go when you're going in for a normal exam or an annual? Is that an annual exam?
Well, what happens at an annual exam is that they check your eye pressure. And again, I recommend the device with the blue light to check the eye pressure. They'll also dilate your eyes and take a look at your optic nerve. And just by looking at the eye pressure and the optic nerve, we can tell if you have some of the risk factors for glaucoma. And then if you have those, you can go on to get the more sophisticated testing.
I see. So if you're going in, if you're just somebody that goes in, and really most people don't go see an eye doctor, unless they're wearing glasses or have contacts, right? They really don't, or they begin to have some type of problem with their vision. So would you recommend then someone who has, I guess you're saying then someone who has a family history of glaucoma, that they actually do get annuals and they eye vision tests, and they need to specifically ask for the glaucoma one. Otherwise, you'll end up getting just the regular vision test, I would imagine.
Correct.
Right? Yeah. Okay, great. Thank you. Let's see. Our next question is from Alan, and he'd like to know, does macular degeneration come on suddenly? Meaning, all of a sudden, first clue is maybe that tunnel vision or the one spot.
So no, macular degeneration itself is a progressive kind of sequence of events, but the symptoms can seem to come on suddenly because, a lot of times drusen, those deposits may not cause any symptoms until all of a sudden there's progression to advanced stages where the bleeding or of wet AMD or atrophy. So that's why it's important to not only, for example, take the vitamins and check with the Amsler grid, but to follow up with your eye doctor so they can monitor for any signs of it on exam that could be followed.
Right. Are floaters in your eye a sign or no?
They're not related to macular.
Yeah. Okay, great. Well, listen, on that note, we're approaching the 8 o'clock hour. So I want to thank the both of you, Drs. Kaleem and Sachdeva, for speaking with us this evening. This was so interesting, wonderful information. We got through most of our questions, not all of them, but the doctors have graciously agreed to respond to any of the unanswered questions. that were asked this evening. So in a couple of weeks, you'll receive an email outlining the outstanding questions and answers. And in the coming weeks, a video of tonight's live stream will be available on our website, the A Woman's Journey website, hopkinsmedicine.org/A Woman's Journey, under videos on demand. And if you enjoyed tonight's discussion, please check out our website, hopkinsmedicine.org/A Woman's Journey, for more information about our upcoming webinars like this evening and our Insights That Matter podcast series, and sign up for our monthly emails. Thank you for joining us. Good night and stay well.
Thank you.